Okay, hello everybody. Thank you so much for have a good opportunity to be here, to have new friends, to spend incredible time in this city. Thank you so much, especially for to foundation of this organization, because the level is incredible high, and thank you so much. I will talk about today unilateral lumbar interbody fusion, and of course about my own experience in this field. We know a little of about my native country, about Ukraine. It is my hometown, Kam'янець-Podilsky. There are very incredible architecture, very nice landscapes, and we have a very nice castle. Kam'янець-Podilsky is located on the southwest part of Ukraine, not far away from Lviv, and about 400 kilometers from Kyiv. This is my clinic, there I work, and you all will be so surprised because it's a very small clinic. It's only 260 square meters, but we have only 4 beds in our clinic, but around 200 UB surgeries a year we have performed. In addition, we have performed also every year master class for Ukrainian participants who was beginners in UV technique. And in addition, we have every week personal workshops for participants from Ukraine. My UB experience: 2019, my first UB, 2020, more than 50 surgeries, all type of herniation. 2021 year, more than 200 surgeries, and at ULBD. 2022, more than 350 surgeries. We add thoracic spine. 2023, more than 500 surgeries. We add ULIF and cervical spine. And 2025, more than 1,000 surgeries, any type of UB. It was my impression after my first ULIF in South Korea. The people who totally changed my life and my mind, they are Dr. Son and Dr. Park. I was in South Korea twice in 23 years. The connection of endoscopic spine surgery and different types of spinal instrumentation is incredible discussable challenge. The performing of UBE lumbar interbody fusion we can consider it as an optimal technique which connect mini-invasive and radical option in one completely surgery. We have analyzed the 34 cases of patients who has done ULIF and 24 patients after traditional open surgery. In all cases, we have performed total discectomy, endoscopic TLIF, and percutaneous TPF. In all cases, we have used standard implants like capstone. It doesn't matter which implant you use, but very important what you can use standard implants. The most important points of ULIF, it's our suggestion: peculiarity of surgical approaches, bone resection and bone harvesting, discectomy and disc space preparation, bone grafting, cage inserting, and percutaneous TIF. The peculiarity of surgical approach is very difficult questions because on the very beginning you have to completely understand what approaches, if you compare the UB and ULIF technique, is completely different. Target point is the same. Position of walking portal is the same too, but we have to use the medial part of incision for cage and lateral part for screw insertion. Endoscopic port must be exactly above the upper perpendicular to have a possibility to insert a screw. It's very important if you have a more than 2-level stabilization. 2 additional incision for screw on contralateral side. Of course, in case of L5 S5 level, we advise to use additional needles insertion to be sure in exact level. It's very important about L5 S1 level. Bone resection and bone harvesting. Almost total resection of EAP. Prefer to use a chisel to have a good material for bone grafting. Resection of CAP must be strongly related with the size of a cage. A small Partial resection of craniomedial part of pedicle is also suggested for comfortable cage insertion. These three options must be done together. Sometimes, especially in case of L5-S1 and in case of listhesis, we advise to do a partial resection of the margin of lower vertebral body to have enough of space for a cage insertion. Discectomy and disc space preparing. Incredibly important. Right after starting discectomy and until finishing cage insertion, we strongly advise to perform surgery with simultaneous visualization with C-arm and endoscopic imaging together. Discectomy must be done almost totally. Both endplates must be cleared very carefully. We have to see exactly the anterior part of annulus fibrosis. Only in this case you have to prolongate your surgery. Bone grafting. Autograft from previously resected EAP and other structures. If not enough, we add to autograft a few grams of allograft. Most of the graft, it's our opinion, more than 90% we insert before the cage. Only 10% we put inside the cage because of 75 or 80% of graft which put inside the cage have lost during hammering. Cage insertion. It's very important. You must all the time during hammering have a two-level simultaneous control of cage position. If you see at this picture, you have in one time see exactly the body of the cage and the lateral margin of the dura by the endoscope. And in this time, you have to see the cage position on the C-arm imaging. Finally, the advice to perform a cage rotation inside the disc space. Percutaneous TF. It doesn't matter which trademark you use, but in my practice I very like Medtronic company. In case of sextant, we use in case of two levels fixation and if we have no instability. In longitude Medtronic implants we use when we have more and 3 or more level and we have to make a good reposition. Post-operative view after this big surgery. The results, the assessment of comparable points, the middle time of surgery, the middle spending time in hospital, the rehabilitation time, and the cosmetic condition. If we compare to this surgery, open and endoscopic surgery, only one position different. It is the time of surgery. In case of open surgery, one level takes about 1.5 hours. In case of endoscopic surgery, in our opinion and in our practice, it's about 2.5 hours, but it strongly depends on the size of disc, on the level of instability. It may be about 1.5 hours to 2.5 hours. But if we compare the time in hospital, if we compare rehabilitation term and cosmetic condition, we will have a conclusion what after endoscopic surgery all this result is better. In case of multi-level surgery, only 1/2 to every level, but another results does not change it. Conclusion, advantages of ULIF. Minimal invasiveness and preservation of multifidus muscle, minimal cosmetic defect, short spending time in hospital, and short rehabilitation term. Disadvantages. Slightly longer operation period strongly depend on surgeon's experience and will be shorter relatively to learning curve. I will introduce some cases. This is a case of L5-S1 listhesis, MRI before surgery, the wound, skin wound after surgery, and CT scan after surgery. It's not a problem if you have a two-level endoscopic lumbar interbody fusion, and no problem in case of 3 or more level surgery. I want to thank you. and take a home message, and always remember, it is a message for the very beginning specialist in this field. And always remember, it's my opinion, USB is not a microdiscectomy through the 2 incision. It's completely different surgery. It's completely surgery which we can never compare with microdiscectomy. Thank you so much.
Thank you so much for your presentation and for sharing your large experience in UBE. Great presentation. Somebody has a question? Okay. In terms of timing, you said that open TLIF, it's 5 days, and UBE TLIF normally 2 days, I think.
Yes, yes.
Do you have any reason why it's 5 days, an open TLIF? It's just for pain control?
Because patients complain of the back pain, they say every day what they want to be in hospital a more longer time, and that's why in my country 5 days is a very short time, because usually in other clinic, not in private, in my private clinic, the middle time of spending after open surgery is more than 10 days. And 5 days is a very good.
That's a very nice reality, because even in South Korea, I was with Dr. Soon and Dr. Park also, and I realized that patients stayed a lot longer compared to Europe. In Europe, aside UBE, yes, it's because of insurance. That's why I was asking you, even open surgery, normally, at least in Portugal, a TLIF can stay 1 to 2 days. But normally our TLIFs are operated in 1 day and are discharged in the other day.
I want to be honestly with you, I forget about open surgery till last 3 years. I forget about open surgery after my performing the ULIF. Yes, I didn't do it.
Yes, but great presentation. Thank you.
Thank you so much.